In this video, we'll discuss the deep muscles of the back, contents of the vertebral canal, as well as intervertebral discs. We'll begin with the deep back muscles, which are also referred to as the intrinsic muscles of the back. The intrinsic muscles of the back help us to maintain our posture, provide stability to the vertebral column, and allow us to control vertebral column movements, which can include flexion, extension, as well as lateral flexion, which is side bending, and rotation. While the movements between any two of the joints of the vertebral column is limited, the effects between all of the vertebrae are additive along the length of the spinal column to allow for a wide range of movements. Because the intrinsic back muscles make most of their attachments alongside of the vertebral column, they are clinically referred to as the paraspinous muscles. The prefix para means alongside, and the word spinous is referring to the spinal column. All of the back muscles we'll discuss are innervated by dorsal primary rami. The four groups of deep back muscles include the splenius, which is composed of the splenius capitis and splenius cervicis, capitis referring to the head, and cervicis referring to the attachments onto the cervical vertebrae. There's also the suboccipital muscles, the erector spinae group, and the transversal spinalis group. Notice that of the transversal spinalis group, you're only going to be responsible for one muscle, called the semispinalis muscle. The largest and most powerful of these groups is the erector spinae group. Let's look at this group first. The erector spinae group, as its name implies, is the chief extensor group of the vertebral column. This group is further divided into three longitudinal columns of muscle. The lateralmost column is called the iliocostalis muscle. The intermediate column is the longissimus muscle, and the medialmost column, positioned immediately against the spinous processes, is referred to as the spinalis muscle. Some individuals like to use the mnemonic I like spaghetti in order to remember the order of these muscles from lateral to medial. These muscles originate from a broad tendon that consumes much of the lower back, which spans from the iliac crest and the sacrum all the way to the lumbar vertebrae. Here's the broad tendon here. Also notice that the erector spinae group of muscles will make multiple points of insertion onto the ribs and onto the thoracic and cervical vertebrae as these muscle columns make their way up the back toward the head. The longissimus capitis muscle, shown here, just behind the splenius capitis muscle, just deep to it, is an extension of the longissimus muscle that attaches to the head. Specifically, the longissimus capitis will attach to the mastoid process, which is the bump located just behind the ear. By way of function, bilateral contraction of this muscle group will result in extension of the vertebral column and extension of the head. And by the way, bilateral contraction means that the muscle groups on each side of the spine are contracting simultaneously, whereas unilateral contraction of the erector spinae indicates that only one side is contracting at a time. Unilateral contraction would result in lateral flexion of the spine in this case. The splenius muscles are flat muscles that converge in the shape of a V along the posterior neck. From the Latin, the word splenion means bandage or splint. So you can envision this muscle being like a bandage draped across the back of the neck. The capitis portion of the muscle attaches to the head. Specifically, the splenius capitis attaches to part of the mastoid process, that large bump behind your ear, as well as the superior nuchal lines. And inferiorly, the splenius capitis is going to originate from the nuchal ligament, as well as the spinous processes of C7 through T3. In contrast, the splenius cervicis will make its attachments from the transverse processes of the cervical vertebrae, and it will originate from the lower thoracic spinous processes. In addition to assisting in the extension of the head and neck, the splenius muscle also participates in lateral flexion and ipsilateral rotation of the neck and head. The term ipsilateral means that the head would be rotating toward the same side that the muscle is positioned on, whereas the term contralateral means that the head would rotate in the opposite direction to the side opposite of the muscle. Again, the splenius muscles will participate only in ipsilateral rotation, along with lateral flexion and extension of the head and neck. And just as a reminder, this muscle, the splenius, is going to be innervated by the dorsal primary rami. There are a number of muscles associated with the transversal spinalis group. We, however, are only going to be concerned with one muscle, and that is the semispinalis muscle. The semispinalis muscle sits just deep to the V-shaped splenius muscle. The semispinalis capitis attaches from the cervical and thoracic transverse processes to the head. If you extend your head with slight ipsilateral rotation, you're demonstrating unilateral contraction of the semispinalis muscle. As you might expect, bilateral contraction extends both the head and the neck. And as a reminder, this muscle is also innervated by dorsal primary rami. The suboccipital region is the area on the posterior neck just inferior to the occipital bone. The occipital bone is shown here. This particular region is of clinical relevance to neurosurgeons, especially when they perform a suboccipital approach to the brainstem. When you dissect this region, you'll want to keep in mind 4 key bony landmarks. As you learned in a previous video, the occipital condyles sit on top of the atlas, as shown here. And recall that the atlas does not have a spinous process. Instead, it has a posterior tubercle on its posterior arch. Like the other vertebrae, C1 does have transverse processes extending from it laterally. And the third leader line is pointing to the bifid spinous process of C2, the axis. The last landmark of relevance here is the occipital bone itself. So again, all 4 key landmarks include the occipital bone, the posterior tubercle of the atlas, the transverse process of C1, and the spinous process of C2. In order to reach the muscles of the suboccipital triangle, you'll first need to reflect the overlying muscles, which include the trapezius, the splenius capitis, and the semispinalis capitis. Once these muscles are reflected laterally, you'll be able to gain access to the 4 muscles of the suboccipital triangle. Let me first provide you with context and orientation by labeling C1 the atlas and C2 the axis. Extending from the bifid spinous process of C2 to the transverse process of C1 is the obliquus capitis inferior muscle. When these muscles contract bilaterally, they cause extension of the neck. When a muscle on one side contracts unilaterally, it causes ipsilateral rotation of the neck. Spanning from the transverse process of C1 to the occipital bone is the obliquus capitis superior muscle. This muscle will cause extension of the head upon bilateral contraction, and it will cause lateral flexion of the head upon unilateral contraction. Attaching from the inferior nuchal line of the occipital bone, as shown by the hashed lines, to the posterior tubercle of C1 is the rectus capitis posterior minor muscle. And the 4th muscle of the suboccipital triangle is the rectus capitis posterior major muscle, which attaches from the inferior nuchal line of the occipital bone down to the bifid spinous process of C2. Collectively, both the rectus capitis posterior major and minor muscles will extend the head and cause ipsilateral rotation of the head. I would also like to point out the posterior atlanto-occipital membrane spanning from the occipital bone to the posterior arch of C1. Within this membrane is a small opening that allows for the passage of the vertebral artery. Not only does the vertebral artery pass through this membrane, but also the suboccipital nerve, C1, exits posteriorly through this membrane in order to innervate the muscles of the suboccipital triangle. While the suboccipital nerve is the motor nerve innervating the muscles of the suboccipital triangle, the greater occipital nerve is a sensory nerve, which carries information from the posterior scalp. The greater occipital nerve is the dorsal ramus of spinal nerve C2. This nerve will be a very useful landmark during dissection because it always emerges along the inferior border of the obliquus capitis inferior muscle. Identifying this nerve and the relationship that it has to the muscle will help you to identify the muscles of the suboccipital triangle. In addition, you'll also need to use all four of your bony landmarks to assist with muscle identification. This slide is a summary slide that gives you a slightly different perspective. In the lower left of the screen, let me just re-emphasize, here's the bifid spinous process of C2, the transverse process of C1, and here's the occipital bone. So again, notice how the obliquus capitis inferior muscle spans between the bifid spinous process of C2 to C1. From there, we have obliquus capitis superior, spanning from transverse process of C1 up to the occipital bone. The rectus capitis posterior minor extends from the occipital bone down to the posterior tubercle of C1, and the major is larger, therefore extends from the occipital bone all the way down to the bifid spinous process of C2. Notice the suboccipital nerve innervating all of the muscles of the suboccipital triangle, and also notice the vertebral artery in the floor of the suboccipital triangle. Now let's take a look at the contents of the vertebral canal. Recall that each vertebra has a vertebral foramen, and when vertebrae are stacked one on top of each other, a canal is formed that runs the length of the vertebral column. We'll call that the vertebral canal or the spinal canal. Working from the periphery of the vertebral canal towards the contents at its center, the canal first contains epidural or extradural fat, which acts as a cushion protecting the contents of the canal. Embedded within the fat is the internal vertebral plexus of veins, as shown here. Next are the various layers of the spinal meninges that envelop the spinal cord. The internal vertebral plexus of veins communicates freely with the external vertebral plexus of veins, as shown here. The communication between these two plexuses is accomplished through the intervertebral foramina. In general, this network of veins runs longitudinally from the base of the skull down to the sacrum. And what's interesting about these veins is that they have no valves, so blood flow can occur bidirectionally. The blood will flow from an area of higher pressure to an area of lower pressure. In the case of metastatic cancer, because of the connections between the external and internal vertebral venous plexuses, cancer cells can infiltrate the meninges and even the spinal cord, moving from the outside inward toward the vertebral canal. In the lab associated with this video, you'll be performing a laminectomy on your cadavers. To perform the laminectomy, you'll remove the spinous processes of the thoracic and lumbar vertebrae. This will allow you to gain access to the vertebral canal, and within the vertebral canal, you'll find the spinal cord wrapped in its layers of protective meninges. The outermost protective layer, just deep to the epidural fat, is the dura mater. When literally translated, this means tough mother. Recognize that when an anesthesiologist anesthetizes a pregnant woman with an epidural, the medication is injected into the epidural space, which contains the epidural fat. So in other words, the needle does not breach the dura mater at all during an epidural procedure. One thing to notice about the dura mater is that it is continuous with the nerve roots as the dural root sheath, and then it blends with the outer covering of the spinal nerve to become the epineurium of the nerve. The translucent arachnoid mater makes up the middle protective layer, and it separates the subdural space, superficial to the arachnoid mater, from the subarachnoid space, just deep to the arachnoid mater. The arachnoid mater itself is a very delicate avascular membrane. In life, the subarachnoid space, just deep to the arachnoid mater, is filled with cerebral spinal fluid that bathes and helps to suspend the spinal cord. While you will not appreciate this in your cadavers, recognize that in life, the pressure of the cerebral spinal fluid in the subarachnoid space pushes the arachnoid mater against the dura mater. This means there really is no subdural space between the dura mater and arachnoid mater. Instead, this is, in reality, a potential space. In the instance of a subdural hematoma, where blood collects within the subdural space, the layers of dura are pushed away from the arachnoid mater. And finally, the innermost layer that is directly adherent to the spinal cord itself is the pia mater. The pia mater is impermeable to cerebral spinal fluid. The pia mater, recognized, will also follow the contours of the spinal cord. Just like the vertebral column is divided into 5 regions, so too is the spinal cord. Emerging from the spinal cord and coursing through the intervertebral foramina are a series of spinal nerves. In total, there are 31 pairs. In parentheses, I've indicated the nerves that arise from each region. For example, the cervical region has 8 spinal nerves associated with it. The thoracic region has 12 spinal nerves. The lumbar has 5, sacral has 5, and there is 1 coccygeal spinal nerve. The majority of spinal nerves are numbered according to the vertebra they exit below. For example, this represents the level of the T12 vertebra, and so the nerve exiting below it is the T12 spinal nerve. This rule, however, does not apply to the cervical region because there are 8 cervical spinal nerves but only 7 cervical vertebrae. So all of the spinal nerves in the cervical region will exit above their respective vertebrae with the exception of C8, which exits below the C7 vertebra. Here is the C8 spinal nerve exiting immediately below the C7 cervical vertebra. Notice how all the other spinal nerves are exiting above their respective levels. Also recognize that the adult spinal level is not the same as the vertebral level because the spinal cord only runs 2/3 the length of the vertebral column. More specifically, the spinal cord ends at the conus medullaris here at the level of L2. This is the L2 vertebra. Here at the conus medullaris is the coccygeal portion of the spinal cord. Notice how the coccygeal portion of the spinal cord is adjacent to the L2 vertebra, so that's the lumbar region of the vertebral column. This is why spinal level and vertebral level do not always match up. If we zoom in at the level of the lumbar vertebrae, you'll notice that the tapering end of the spinal cord, called the conus medullaris, terminates at the L2 vertebral level. Therefore, the nerve roots that come from the lumbar region of the spinal cord course inferiorly within the subarachnoid space and eventually exit below their respective vertebral levels. The bundle of dorsal and ventral nerve roots coming from the lumbar, sacral, and coccygeal spinal levels is collectively referred to as the cauda equina. The anatomist who named this structure thought that it resembled the tail of a horse, hence its name. Extending from the conus medullaris is the filum terminale internum, which is an extension of the pia mater that tethers the spinal cord to the coccyx. At the end of the dural sac, which terminates at the level of S2, the filum terminale continues as the filum terminale externum, which is wrapped in dura mater. The filum terminale externum then emerges through the sacral hiatus to attach to the coccyx. The lumbar cistern is the enlargement of the subarachnoid space in the lumbar region. This same region is where a lumbar puncture is performed. A lumbar puncture is a spinal tap performed to remove cerebral spinal fluid from the subarachnoid space. There are numerous indications for why a puncture is performed. One example would be to test for meningitis. To perform a lumbar puncture, the patient rolls into the fetal position, which is known as the decubitus position. A needle is then inserted within the L4-L5 intervertebral space. This space happens to be at the same level as the iliac crests. Therefore, anesthesiologists use the iliac crests as their landmark and reference point. If the needle is inserted into the midline, it will pierce a number of structures, including the skin, the supraspinous and interspinous ligaments, ligamentum flavum, and the arachnoid dura mater interface. Recall that the arachnoid mater is immediately adherent to the dura mater as a result of the pressure of the cerebral spinal fluid within the subarachnoid space. Once the needle has entered the subarachnoid space, the cerebral spinal fluid can be withdrawn. Recognize that this is a relatively safe procedure. Picture all of the cauda equina in this space as spaghetti. Now imagine you're trying to use the tines of your fork to stab a piece of spaghetti. Because that spaghetti is cylindrical, when the tines come into contact with the cylindrical spaghetti, the spaghetti just rolls out of the way. Well, the same concept is true here when the needle enters the subarachnoid space and potentially comes in contact with one of these nerve roots. Because they're cylindrical, they just roll out of the way of the needle. Here are the nerves emerging from the spinal cord and how they coalesce to form a spinal nerve. First, we have dorsal and ventral rootlets. Technically, we would say that the dorsal rootlets are entering into the spinal cord, while the ventral rootlets are exiting the spinal cord. Once the dorsal rootlets converge, they form a dorsal root. Likewise, once the ventral rootlets converge, they form a ventral root. Going into the dorsal root is something called the dorsal root ganglion. This is where cell bodies of pseudounipolar neurons are housed that are carrying sensory information back to the spinal cord. You'll sometimes hear this referred to as the spinal ganglion. Once the dorsal and ventral roots unite, they together form a spinal nerve, shown here. The spinal nerve is relatively short, and recall that it exits through the intervertebral foramen. Upon emerging from the intervertebral foramen, the spinal nerve divides into both a dorsal and ventral primary ramus. Notice how the dorsal primary ramus is much smaller in diameter than is the ventral primary ramus. The spinal cord is suspended in the dural sac by small saw-toothed ligaments called denticulate ligaments, shown here. These ligaments are lateral extensions of pia mater, and each of 21 pairs of denticulate ligaments separate the ventral from the dorsal nerve roots. These denticulate ligaments are like spot welds that adhere to the dura mater. They help to stabilize the spinal cord within the vertebral canal. In this section, we'll take a closer look at the vertebral ligaments and intervertebral discs. Along the length of the vertebral column, there are a series of ligaments that help to stabilize and reinforce the spine. The anterior longitudinal ligament is a very strong fibrous band that covers and connects the vertebral bodies along their anterior surfaces. The ligament runs from the sacrum to the anterior tubercle of the atlas, C1. Functionally, this ligament resists hyperextension of the vertebral column. Imagine being in a car accident in which someone rear-ended you from behind. This would cause a whiplash injury in which your neck would slap backwards into full extension and even hyperextension. So again, this ligament, the anterior longitudinal ligament, helps to prevent hyperextension of the vertebral column, specifically in the neck. Its less impressive counterpart is the posterior longitudinal ligament. This ligament is narrower in width, it is weaker, and it runs within the vertebral canal along the posterior border of the vertebral bodies. The posterior longitudinal ligament extends from the sacrum to the axis, C2. This particular ligament is going to help to resist hyperflexion of the neck and of the vertebral column, and it's going to also help to keep the intervertebral discs from slipping posteriorly. The remaining three ligaments are considered accessory ligaments of the intervertebral joints, the first of which is the ligamentum flavum. The ligamenta flava are bridging ligaments that span between the laminae of the vertebrae. From the Latin, the word flava means yellow, so in lab you'll recognize that these particular ligaments have a yellowish tint to them. Just like the posterior longitudinal ligament, these ligaments also help to resist flexion, hyperflexion of the vertebral column. The spinous processes are joined by a weak membranous-like ligament called the interspinous ligament, shown here. A much stronger fibrous cord-like ligament called the supraspinous ligament runs along the tops of the spinous processes. The supraspinous ligament runs from the vertebra prominens, which is the spinous process of C7, all the way down to the sacrum. The ligamentum nuchae, which we've encountered already, is a continuation of the supraspinous ligament that runs all the way up to the external occipital protuberance. Separating the bodies of adjacent vertebrae are intervertebral discs. The first intervertebral disc starts at the C2-C3 interspace, and the last disc ends at the lumbosacral joint at the L5-S1 interspace. In total, intervertebral discs account for about 20 to 25% of the length of the vertebral column. They allow small movements between the vertebrae, and their resilience and their ability to deform makes them excellent shock absorbers, as long as they are hydrated. Each intervertebral disc is sandwiched between a thin layer of hyaline cartilage that lines the surface of the vertebral bodies. It's also worth mentioning that the intervertebral discs contribute to the antero-inferior boundary of the intervertebral foramen. If I draw in an intervertebral foramen here, notice how this disc contributes to this area of that foramen. This particular fact has clinical significance, which we'll address in just a moment. Each intervertebral disc contains an outer ring made up of layers of fibrocartilage called the annulus fibrosus. They also contain an inner gelatinous core, which is referred to as the nucleus pulposus. Recognize that the nucleus pulposus is a remnant of the notochord in the embryo. Recall that the notochord was a signaling center that told the neural tube when to develop. There are a number of different pathologies associated with intervertebral discs. A degenerative disc is basically a collapsed disc in which the fibrocartilage and the nucleus pulposus have lost their integrity. At birth, the nucleus pulposus is about 88% water, contributing to both its flexibility and its resilience. Throughout the normal aging process, the nucleus pulposus desiccates, and it loses its ability to rebound upon compression. A bulging disc is an outpocketing of the annulus fibrosus, as shown here. Notice how the annulus fibrosus is still intact, however it has a posterior dilatation associated with it. Bulging discs are more common than herniated discs, and they typically cause no pain. Herniated discs, however, typically present with back pain and potentially other neurological deficits. Herniated discs are also referred to as ruptured discs or slipped discs. The term slipped discs, however, is a bit of a misnomer because the disc is not slipped at all. The herniation of a disc occurs when the nucleus pulposus slips through a crack in the annulus fibrosus and begins to bulge posterolaterally. And to complicate matters, bone spurs, which are referred to clinically as osteophytes, can form on the surfaces of the vertebral bodies, further compressing an intervertebral disc. Let's take a closer look at disc herniation. It's worth pointing out that the nucleus pulposus is not positioned in the center of the intervertebral disc. It's actually positioned more posteriorly because the lamellae of the annulus fibrosus are thinner posteriorly than they are anteriorly. And just a few moments ago, we learned that there is a ligament called the posterior longitudinal ligament, which runs along the anterior surface of the vertebral canal, as shown here. Recall this ligament is narrower than the anterior longitudinal ligament, and it's also weaker than the anterior longitudinal ligament as well. Therefore, the herniation takes the path of least resistance, and it protrudes posterolaterally just to the side of the posterior longitudinal ligament. Realize that flexion of the vertebral column compresses the intervertebral discs. When this happens, the nucleus pulposus is further squeezed out posteriorly, thereby leading to pain upon bending, because notice how this herniation is affecting the spinal nerve nearby. This is especially true of cervical vertebrae. In the case of lumbar vertebrae, the nerve roots below the level of compression will be affected instead. Allow me to explain. First of all, notice how large the intervertebral foramen is, which is associated with the lumbar vertebrae. These foramen are not nearly this large in the cervical region. Also recall that the intervertebral disc forms the inferior and anterior boundary of this intervertebral foramen, specifically within the lumbar vertebrae. Because this intervertebral foramen is so large, the spinal nerve is going to slip out along the top half of the intervertebral foramen. Notice how the intervertebral disc is actually making up the lower boundary of that foramen. So when the intervertebral disc herniates posteriorly, it misses the spinal nerve that is exiting at that same intervertebral level. Instead, it can impinge upon the nerve root of the spinal nerves that exit one below. So in this case, if we have an L4, L5 disc herniation, it will not impinge upon the L4 spinal nerve at all, but rather it could impinge upon the nerve root of L5. These types of herniations can cause lower back pain and even lower limb pain. Approximately 95% of all lumbar disc herniations or protrusions occur at either the L4-L5 or the L5-S1 interspace. Here's an example of an L3-L4 disc herniation. Notice how the sacrum is slanted here. That indicates that this area is the sacrum and this is the L5 vertebra. This therefore would be L4 and L3. So when you're viewing medical imaging, use this slant of the sacrum to help you indicate where you're at. Because the cervical intervertebral discs are more centrally located in relationship to the intervertebral foramen, a cervical herniation impinges upon the cervical nerve exiting at the same level. And don't forget that the cervical nerves exit above their respective vertebrae for C1 through C7. So here's an example of a C5, C6 disc herniation. Notice how it's impinging upon the C6 spinal nerve, which exits just above the C6 vertebra. There's only one rule that you need to remember when it comes to disc herniations, and that is that the nerve impinged by a herniated disc is always the bottom number of the disc that's herniated. So in the example we just gave, the bottom number of the disc is C6, therefore that is the nerve that will be impinged. This same rule also applies to the lumbar vertebrae. So let's imagine we have an L3, L4 intervertebral disc herniation, in which case it's going to miss the L3 nerve that exits just below L3, and in fact will impinge upon the L4 nerve root. So this same rule applies for both regions, whether in the cervical region or the lumbar region. We typically don't talk about disc herniations in the thoracic region because they're so uncommon. They're very rare. However, they can occur. To reinforce these concepts, let's take a look at a case. Upon physical examination, a soldier demonstrates unilateral weakness in retracting and elevating his right scapula. In addition, he has numbness and tingling in his shoulder in the area where the U.S. flag is embroidered on his military uniform. The combat physician suspects a herniated cervical disc, which is later confirmed by MRI. Which cervical disc is herniated? To begin to answer this question, we first need to pull out some key information. Notice that this patient has unilateral weakness in both retracting and elevating his right scapula. So let's first think about the muscles that cause these actions on the scapula. In regards to scapular retraction, there are two muscles that could be involved. The first could be the trapezius, which I'll abbreviate TRAP, and the second could be the rhomboids, which also retract the scapulae. Next, let's think about what muscles elevate the scapulae. Well, again, the trapezius muscle, specifically its upper fibers, will help to elevate the scapula, and the levator scapulae muscle will also participate in scapular elevation. Now let's remind ourselves what nerves innervate each of these muscles. The trapezius muscle we know is innervated by cranial nerve number 10, which is a spinal accessory nerve. This nerve is not associated with the cervical region at all because it comes from the brainstem. Since we know that this is a cervical disc herniation, we can rule out the trapezius muscle being affected in this case. That leaves us with the rhomboid muscle and the levator scapulae. You might recall that both of these muscles are innervated by the same nerve called the dorsal scapular nerve. and the dorsal scapular nerve happens to come from the C5 spinal nerve. There's actually more information within the case that helps us to know that C5 is affected. Notice that the patient also experiences numbness and tingling in his shoulder, specifically over the area of the U.S. flag where it's embroidered on his uniform. This particular area is referred to as the deltoid skin patch. You've not learned this just yet, but you will soon. The deltoid skin patch happens to be associated with C5 as well. So all of these signs point to C5 being compressed by a herniation. So now if we walk back to this picture, the disc that is herniated would be the C4, C5 intervertebral disc. And so that's our answer to the question. Let's briefly review the components of a typical lumbar vertebra. Number 1 would represent the vertebral body. Number 2 is an example of the transverse process. Number 3 would be the pedicle. Number 4 with the large arrows pointing to the vertebral foramen. Number 5 indicates the superior articular process with its facet on it. And number 6 represents the spinous process, which is hatchet-shaped in the lumbar vertebrae. Number 7 indicates the lamina. Number 8 would indicate the inferior articular process. And last but not least, number 9 represents the pars interarticularis. As a reminder, the pars interarticularis is the area between the superior and the inferior articular facets, shown here. When looking at the lumbar vertebra from an oblique angle, this particular area represents the silhouette of a Scotty dog. And again, the pars interarticularis is the area of the neck of the Scotty dog. I mentioned this in the last video, but I would like to emphasize it here. The pars interarticularis is important clinically because of stress fractures of the lumbar vertebrae which commonly occur at the pars interarticularis. A crack or a stress fracture of the pars is called spondylolysis, and this is what it looks like. If that fracture results in spine slippage, in which the vertebra above slips forward off of the vertebra below from its normal position, that is called spondylolisthesis. And usually the fifth lumbar vertebra shifts forward on top of the sacrum because of this slant associated with the sacrum. Here's a radiograph of a normal lateral oblique view of a lumbar vertebra. Notice how you can see the superior articular process and the inferior articular process, along with the transverse process here. And so this area of the neck between the articular processes again represents the pars interarticularis. Now here's what spondylolysis looks like, which is a fracture of the pars interarticularis. I've outlined the area of the fracture here. Notice where the arrows are pointing to, there's a fracture. Above this would be the superior articular facet. Below this would be the inferior articular facet. And the neck of the Scotty dog is fractured, indicating spondylolysis. Again, if the spine now slips forward as a result of this fracture, we would call that spondylolisthesis. In the lab associated with this video, you'll be performing a laminectomy in order to visualize the spinal cord. Here are the dissection instructions to help guide you through this process of the laminectomy. You're first going to reflect the superficial back muscles in order to identify the deep back muscles. Once that's done, you can then begin to prepare for the laminectomy. First, let me point out the area of the paraspinal gutter. The paraspinal gutter is the area between the spinous processes and the transverse processes. It's within this gutter where you're going to make your cuts for the laminectomy. However, to get there, you first need to use a chisel to pry away the spinalis muscle away from their attachments on the spinous processes. Once the gutter is cleared of muscle, you can then take a chisel or a saw and you can sever the exposed laminae bilaterally from T4 all the way down to L4. And notice you need to do this at a 45-degree angle. This is key. If the angle is too sharp, you'll actually shear off the transverse processes. If the angle is too low, you will shear off the spinous process. So going in to make your cuts at a 45-degree angle will gain you access to cutting the laminae only. Once your cuts are made bilaterally, you will remove this section of the spinal column as a single unit. To accomplish this, you'll first need to make a transection at the T4 and L4 vertebrae. Then the spinal column where the cuts were made should come out as one unit. Once the spinous processes and the parts of the laminae are removed, you'll then be able to visualize the spinal cord. Specifically, the first thing you'll be seeing is the dura mater. From there, you'll take a iris scissors, and you'll make a longitudinal cut through the dura mater to expose the spinal cord itself. This concludes this video. If you have any questions, don't hesitate to email me or stop by my office, or catch me in lab. Until next time, happy studying.